Welcome back to the deep dive, where we take complex source material and just give you the absolute non-negotiable takeaways.
That's the plan.
Today, we are strapping in for a uh, pretty serious topic in cardiac care antianginal agents. We're breaking down Chapter 46 of Focus on Nursing Pharmacology.
Right. And our mission here is really specific. It's to understand how these drugs restore that critical balance between oxygen supply and oxygen demand in the heart muscle.
And this isn't just academic. We're talking about coronary artery disease, CAD, which has been, well, it's been the leading cause of death in the U.S. for a long time.
For a very long time.
Yeah.
Mastering these agents is about preventing real, irreversible damage. It's about preventing cell death.
Okay, so here's the game plan. We're going to start with the problem itself, CAD and angina. Then we'll get into the solutions, the three main drug classes, nitrates, beta blockers, and calcium channel blockers.
And we'll finish with the newer agent, ranolazine, and then tie it all together with some key nursing responsibilities.
Perfect. So let's start with the engine trouble. What exactly is going on in CAD?
It all starts with the progressive narrowing of the coronary arteries, the vessels that feed the heart itself. A fatty plaque, which we call an atheroma, starts building up in the artery walls.
And as that plaque grows, the artery gets narrower and it also gets stiffer.
Exactly. That whole process is called atherosclerosis. I mean, a good analogy is thinking of the coronary arteries like your car's fuel lines. They're getting clogged and they're losing their flexibility. The fuel delivery is it's compromised.
And here's a detail that I think surprises a lot of people. The heart muscle gets its blood supply during diastole.
Yes, during rest. Not when it's actively contracting, which seems counterintuitive.
Right.
When the heart squeezes during systole, the muscle contraction literally clamps those coronary vessels shut. It's only when the ventricles relax that the aortic valve closes, blood flows back, and it's pushed into the coronary arteries.
So the force delivering that blood is the pulse pressure.
That's it. The difference between your systolic and diastolic pressure. If those fuel lines are narrowed, or the pressure isn't strong enough, well, the heart starts to suffocate.
And that suffocation, that oxygen imbalance, that's what we call angina pectoris.
Literally suffocation of the chest.
The pain itself comes from ischemic cells releasing something called substance P, right?
Yes, and that's why the pain isn't always just in the chest. It can radiate. Patients feel it in their left arm, their jaw, sometimes even their teeth.
And defining the type of angina is, I mean, that's step one for choosing the right drug.
Absolutely critical. First, you have stable angina. It's predictable, the pain comes on with exertion, and it's relieved by rest. It's consistent.
Then you have the much scarier version, unstable angina.
Right, sometimes called pre-infarction angina. This is where the pain starts happening unpredictably, or worse, at rest. That's a huge red flag that the blockage is getting severe.
And the third type is the real outlier.
Prinzmetal angina. This one isn't just about plaque. It's caused by a sudden, intense vasospasm, a clamping down of the coronary arteries, and treating that requires a completely different approach.
If the vessel gets completely blocked, the end result is a myocardial infarction, an MI.
The heart muscle tissue starts to die from lack of oxygen. It becomes necrotic. And beyond that permanent damage, the immediate danger is fatal arrhythmias. The surrounding muscle gets really irritated.
Okay, so problem established. Poor supply, high demand. The drugs have to do one of two things.
Right. Either increase supply by dilating the vessels, or, more commonly, decrease demand by making the heart's job easier.
Let's start with the classic, the fire extinguisher for chest pain. The nitrates. The prototype is nitroglycerin, or NTG.
And its main job is to slash that oxygen demand.
How does it work so fast?
It acts directly on smooth muscle, causing this potent relaxation and vasodilation. The key effect here is a massive drop in something we call preload.
Preload. So that's the amount of blood filling the heart before it pumps.
Exactly. The veins dilate, blood starts to pool out in the body, away from the heart, so less blood returns to be pumped.
Less blood coming in means less work to pump out. Makes sense.
And it also dilates arteries, which reduces afterload. Think of afterload as the resistance the heart has to push against. It's like trying to push open a really heavy, sticky door. Nitrates make that door easier to open.
So less strain, less oxygen needed.
Precisely.
And NTG comes in a ton of forms: sublingual, spray, IV, patches, ointment.
It does, and the onset and duration are wildly different for each one. And speaking of the ointment, there's a fascinating detail in the source material. In 2011, the FDA approved a specific nitroglycerin ointment, Rectiv, to treat anal fissures.
Because it relaxes smooth muscle so powerfully.
Exactly. It's a great illustration of the mechanism. But, and this is the critical safety point, That specific product is not for treating chest pain.
Okay, let's get into the crucial nursing points for angina relief. For that fast-acting sublingual tablet, what is the absolute do not do?
Do not swallow it. It has to dissolve under the tongue. The mucous membrane should be moist to help it absorb. If you swallow it, it's just destroyed by the stomach and liver. It won't work.
And patients might feel a little fizzing or burning.
They might, yeah. That's actually a sign that the tablet is still potent.
And what's the protocol for an acute attack? The 1-2-3 rule.
You take one dose. If the pain isn't gone in 5 minutes, you can take a second. And if it's still there after another 5 minutes, you can take a third.
But after that third dose...
If the pain is still there, it's a medical emergency. You call 911, that's the hard line.
And for the long-acting patches, there's a safety rule that is absolutely non-negotiable.
100%. You must remove the old patch and wash the area before you apply a new one. Always.
Yeah.
If you don't, you're stacking doses, and that can lead to severe, life-threatening hypotension.
Which makes sense because all the adverse effects come directly from that vasodilation headache, dizziness, and of course, hypotension.
And that can trigger what we call reflex tachycardia. The body feels the blood pressure plummet and tries to compensate by making the heart beat faster, which, kind of defeats the purpose by increasing oxygen demand again.
But there is one safety alarm that we have to sound louder than any other, the ultimate contraindication.
Yes. This has to be in every single patient teaching plan. Nitrates combined with phosphodiesterase inhibitors, that is ED drugs like sildenafil, tadalafil, or vardenafil, is an absolute non-negotiable contraindication.
What do you think happens?
You get this massive synergistic vasodilation. The two drugs together cause a catastrophic drop in blood pressure. It can lead to cardiovascular collapse.
Okay, that's a huge warning. Let's move to our second class, the beta blockers. The prototype here is metoprolol.
Right. If nitrates are the fire extinguisher, beta blockers are like the long-term governor on the engine. They just slow everything down.
How do they do that?
They block beta-adrenergic receptors. They basically dial down the influence of the sympathetic nervous system, the fight-or-flight response on the heart.
So the heart becomes less excitable, pumps out less blood with each beat.
And its overall oxygen consumption goes way down. That's why they're so important for the long-term management of angina from atherosclerosis.
And they're really critical after someone's had an MI, right?
Yes. Metoprolol and propranolol are routinely used to prevent a second heart attack and just improve long-term outcomes.
But there's a big exception. You mentioned Prinzmetal angina earlier. Why are beta blockers a huge mistake for that?
Because Prinzmetal is caused by that vasospasm. Beta blockers could potentially lead to what we call unopposed alpha-adrenergic stimulation, which would actually make the coronary artery constriction worse. You could exacerbate the spasm.
Good to know. And a few quick cautions. They can mask the signs of hypoglycemia in diabetics, and you have to be careful with patients who have asthma or COPD.
Right, due to the risk of bronchospasm.
Okay, that brings us to our third class. The calcium channel blockers, or CCBs, like diltiazem.
These are the pipe openers.
Yeah.
They work by inhibiting the movement of calcium into the muscle cells of the arteries and the heart itself.
And less calcium means less contraction.
Exactly. In the arteries, that means massive vasodilation. That lowers peripheral resistance, so it drops both preload and afterload.
But this class has a special advantage for one type of angina in particular.
This is their superpower. They're incredibly effective for Prinzmetal angina because they directly relieve that coronary artery vasospasm. They're often a first-line therapy for it.
Now, we do need to differentiate between the types of CCBs.
We do. The non-dihydropyridines like diltiazem and verapamil have a stronger effect on slowing the heart rate and reducing the force of the pump.
Which makes them more potent, but also maybe more dangerous.
More dangerous for patients who already have heart failure, yes. You have to monitor them very closely for signs of decreased cardiac output, a slow heart rate, and hypotension.
And there's a specific drug interaction with verapamil we need to highlight.
Verapamil and digoxin. You have to be extremely cautious. Verapamil can actually increase the serum levels of digoxin, which raises the risk of digoxin toxicity. Plus, both drugs together increase the risk of heart block.
All right, let's get to the newcomer. The piperazine acetamide agent, ranolazine or Ranexa.
This one is fascinating. It was approved in late 2006, the first new class for chronic angina in over a decade.
And what's so interesting is how it works. Or rather, that we don't fully know how it works.
Exactly. The mechanism isn't completely understood. But we know it decreases the heart's workload and restores that oxygen balance without really affecting heart rate or blood pressure.
That's a huge deal for patients who can't tolerate the side effects of the other drugs.
It's a game changer for them. but it comes with its own major safety flag.
The big one?
It prolongs the QT interval on an ECG. This increases the risk of some very serious ventricular arrhythmias, so it's strictly contraindicated for anyone who already has a long QT interval or is taking other drugs that are known to do the same thing.
And for administration, the extended release tablet has to be swallowed whole. No cutting, crushing, or chewing.
And like so many other drugs, avoid grapefruit juice.
Okay, let's bring all this pharmacology back to the bedside. What are the big holistic nursing takeaways?
Well, number one is implementation safety. With all of these drugs, because of that immediate risk of hypotension, you have to make sure the patient is sitting or lying down before you give them the medication.
You're trying to prevent a fall.
You're preventing a fall and a potential injury. It's paramount. Then there's withdrawal safety.
This is for long-term therapy.
Yes. You can't just stop these drugs abruptly. The dose has to be tapered down gradually, usually over 4 to 6 weeks, to prevent a dangerous rebound effect like severe chest pain or even an MI.
And finally, teaching. Medication is only one part of the puzzle.
It is. We have to teach the non-pharmacological stuff that makes the drugs work better. Things like weight loss, stopping smoking, avoiding excessive alcohol or coffee.
And pacing activities. I think the book mentions not climbing stairs right after a big meal.
Yes, because digestion itself puts a huge oxygen demand on the heart. It's about being smart with your energy. And one final thought on older adults. They are much more likely to develop adverse effects, so they should always start on a lower dose.
That was a fantastic deep dive. So, to quickly recap, CAD creates an oxygen deficit. Antianginal drugs fix it, mostly by reducing the heart's energy demand.
And you have your acute treatment, like sublingual NTG, and your long-term management with beta blockers, CCBs, and ranolazine. And you have to match the drug to the type of angina.
Right. And that matches everything.
It is. And it leaves me with one final thought for you to consider. If the whole pharmacological goal is to decrease the heart's workload, how can we empower the patient to do that themselves? If they know their own trigger stress, cold weather, that heavy meal, they can learn to avoid them. In a way, they become their own first-line natural antianginal agent, making every single drug we've talked about work that much better.
A profound thought on giving patients agency in their own care. Thank you for joining us for this deep dive into antianginal agents. Keep seeking knowledge, and we'll catch you next time.